Okay, we're going to turn the front lights down a little bit. Okay, great. So I'm starting with something that's fairly common to many places in Asia and Australasia. So, you know, we go to conferences where we see the Americans who have these very fancy brain tumour centres, and many of us work in more resource limited centres. And so the idea of how can we build a really top class brain tumour service, multidisciplinary brain tumour service in the setting that we are in is a question that people often ask me. And so this is how we've slowly developed our brain tumour service in Melbourne, and I'm hoping it will have some useful messages. So this is my hospital. Can you see my? Yes. So here is the Peter MacCallum Cancer Centre. It's the shiny new building that the government recently built. But this building back here, which was built in 1940 and is actually falling down, that's my hospital. So we don't all necessarily have some wonderful infrastructure. But we have built a very good brain tumour multidisciplinary service on the basis of the three pillars of clinical care, education, and research. And they're the three things that you should be looking towards to have your own brain tumour service, which is growing and from which you are constantly developing to better the practice that you have. Now, this didn't happen for us like that. In fact, what we had to do was very slowly build it, and so it was an incremental change. And these were the basics that we developed. So a multidisciplinary team and a tumour board, I think, is the foundation of it all, starting to build your personnel, finding people who are interested in brain tumour care. Eventually adding surgical techniques, learning new techniques, bringing them into your setting in a way that's possible. Collecting data. Unless you are collecting what you're doing, you will not know whether you're improving, and you will not know what your practice is like. Tissue banking. If you're thinking of research, doesn't have to be every tumour, but having a small tissue bank from which you can build research, I think, is important. Undertaking both clinical research, which is everybody can do, laboratory research if you can, but that's not essential. Making sure that you're caring for your patients, not just thinking about an operation or chemotherapy, but thinking about the supportive care of your patients. Being involved in clinical trials, and all of this will then lead to excellent clinical care. Now, obviously, you may not be able to do all of those things in your setting, but these are the building blocks of a great service. So this is me and Mark Rosenthal. Mark is a medical oncologist, and we've pretty much, when I came back from my fellowship in Boston in 2004, it was him and me. And the clinic was me in one room and him in the next room, and that was the entire multidisciplinary service. But over the years, we've added staff and we've grown. And so now our tumour board includes neurosurgeons, and I try and encourage all neurosurgeons who treat tumours to be involved in the tumour board, the multidisciplinary team discussion, trainees and fellows. We have medical oncologists, radiation oncologists. We have a neurologist for the seizures. We have our pathologists and our radiologists, obviously. We have a psychiatrist who cares for the patients who have psychiatric and psychological problems. We have a nurse care coordinator, other nurses. Sometimes our researchers come to the tumour board so that they can understand the clinical management of our patients. We have our PhD students and scientists, and sometimes we even had a vet neurosurgeon come along who looked after dog brain tumours. So I can say I'm the only neurosurgeon that I know of who has a trans-species multidisciplinary team meeting. Obviously, that's not essential to have a vet. Really, at the heart of our multidisciplinary team is our fellows. They undertake a lot of research, and it's enormously enriching to have people from overseas bring their experience. So in that group, we've got from Dominican Republic via Israel, Sweden, Poland, and the United States. So having that international interaction, I think, has been very enriching. What does our tumour board look like? Well, we don't discuss every case. A simple glioblastoma that is always going to go to radiotherapy and chemotherapy, there's no need for discussion of that patient, because otherwise it becomes a very, very, very long tumour board with many, many, many patients going glioblastoma, radiotherapy, chemotherapy, glioblastoma, radiotherapy, chemotherapy. So we only really discuss the controversial cases or for ones for which there's a genuine decision to be made. We look at the molecular data associated with the tumour, and I think that educates neurosurgeons. We often don't understand a lot of the histopathology, so being a part of the tumour board is educating. It helps us know what clinical trial options are available for our patients, and it has a strong educational focus. We'll often ask questions to try and make sure that the trainees or the researchers or the people from different specialties learn something, and it has to be made fun and interesting, otherwise people don't attend. So instituting a tumour board or a multidisciplinary session, even if it's only once a month with a few interesting cases, I think is the foundation of a multidisciplinary service. You can then start adding advanced surgical techniques. And I think for tumours, in fact, the multidisciplinary team is more important than the surgical techniques. That's a second thing. For me, that has been, I think, the first thing that in any setting you can add is awake craniotomy. And I'm going to talk about that later, so I won't go through the details, but that to me is the most cost-effective thing that you could add in any setting to improve your outcomes for your patients with brain tumours. I think the next one is Gliolan, but of course that becomes very expensive. It can be a very expensive drug, but fluorescence-assisted resection, of course, is really becoming the standard of care. After that, you start to get to things that are not possible in most settings, and I don't think are necessary. We have an intraoperative MRI, but we use it not frequently. So I actually don't think it's worth the money. The only good thing about it is it's in the next room, and we can also do MRI scans while we're operating. So it gave us another MRI scanner. But of course, and we're having talks on this later, intraoperative ultrasound is a pretty cost-effective way of having intraoperative imaging, and we'll have some talks about that later. Collecting data is essential. So this is our database, the brain database. This is about the 7th iteration of our data collection. If you're not collecting data about your patients, you don't know what your outcomes are. So I collect my data both personally, but also in the institutional database. I can tell you what my infection rate was in 2007 from my own personal data collection. But from this, we can tell how the whole institution's doing. This program, we have no proprietary interest over. If you want to start collecting data in your institution, then we can make this program available to you. But from this data has come all of our publications. So many publications from various people who we've had working and doing research in the unit has come from the data collected in this database. There's your paper, Tanya. I thought I'd put that in. All coming from data that's collected in our database, plus tissue that we've collected. So all of these papers over the years have come from the data that we've collected. We've made it part of our workflow, so our residents input the data, which means that every patient is in the database rather than having a data collector or anything else. So we've made it part of our workflow. More. The next step, which is probably not going to happen everywhere and probably shouldn't happen everywhere, so that's clinical research that results from data, is whether you're going to start laboratory research. We've been very strong on this, thanks to the legacy of Professor Kay and the fact that that picture that I showed you, we sit right in the middle of the University of Melbourne, the Walter and Eliza Hall Institute. We sit right in the Florey Institute of many research institutes. So it makes it very easy for us because as neurosurgeons, you have a lot of power. And I'll tell you why you have a lot of power, because you have the tissue. And everyone who's doing research wants tissue. So you can collaborate with people doing research by providing the tissue. So every one of my patients is consented when they come to the hospital to have their tissue and their data collected for research, and from there flows the research. So it's really important. And around that, we've also built a second meeting, which is the Brain Tumour Research Group meeting, where we present our research. These specimens are extremely valuable, and if you can make links with any laboratory researchers in your country, you will find that the research will flow from there. Supportive care, of course, is very difficult because it takes a lot of people: physiotherapy, psychology, nurses, occupational therapy, and in many settings, including ours, it is inadequate for the care that the patients need, palliative care, etc. One thing that we're doing to try and improve that situation is start a digital health platform for supportive care, which I might talk a little bit about later, but this is called Brain Tumours Online. You never know, it might go worldwide. At some stage, brain tumour patients from Vietnam may be using Brain Tumours Online. But it has 3 pillars: an information pillar called Learn, where patients can find out all the information they need to know about their tumour, and signposted, so that if you have a glioblastoma, you don't end up with the information about a low-grade glioma. A community pillar, which is basically a social network pillar for other patients, for patients to connect. Australia is a big country with a small population. So if you're in the north of our state, a 35-year-old mother with a low-grade glioma, your ability to connect with someone else in a similar situation as you is very unlikely in your local town. But if you can connect with all of those people in Melbourne, the big city, electronically, then that's very good for supportive care. And the third pillar is the toolbox pillar, which has interventions for common problems experienced by our brain tumour patients, such as sleep disturbance. So they can go on and do an online cognitive behavioural therapy program over 6 weeks for the sleep disturbance associated with brain tumours and other types of cancer. Clinical trials. The reason to develop clinical trials in your practice is because patients who are on clinical trials live longer, even if they are on the placebo, because clinical trial medicine is good medicine. So we looked from our data collection, all our patients who are on clinical trials and those patients who weren't, and even when we corrected for age, performance status, etc., the patients who were on clinical trials, even if they were on placebo, lived longer than the patients who were not on clinical trials. So trying to add clinical trials into your practice, I think, is very important. Building a clinical trial portfolio, though, is actually very difficult. Let me tell you, trying to get the ethics approval from our ethics committee to undertake a clinical trial usually makes me lose the will to live. There is so much paperwork, but I think it's worth persisting. But, you know, trying to get an either getting an approved protocol or selecting investigators or the approval process, which is what I was talking about, is so much work. But having said that, once you start recruiting patients, you'll see the real joy in being able to say to your patients who have really not many options, here, we have this additional for you, is really something that will bring great interest and joy to your practice. And of course, then you go down the whole line of statistical analysis and data entry. If you're a small centre, then it's quite good to just become part of a larger study. And this part of the analysis, the data entry and the presentations, that will actually be part of the bigger cooperative. And so if you can become part of another trial, that would be really great. So what do I conclude? So, Bill, if you really want to care, I put glioblastoma there, but it's actually all brain tumours. If you really want to care for your brain tumour patients in the best way, then you need to build a multidisciplinary team, because this is the key in the step to good clinical care. It's incremental. It won't happen overnight. Find a medical oncologist who's interested. find a radiation oncologist, get a pathologist who wants to learn more about brain tumours, gradually build that capacity. But it benefits patients, it benefits the providers of the care, and it benefits research. Embedding research into your clinical practice will improve care and improve engagement of both patients and of the people caring for them. And remembering that clinical trial medicine is good medicine, and every patient should be given the opportunity to be on a clinical trial should be your ultimate game. We haven't got there yet. We don't have a clinical trial for every one of our patients, but we're working towards that. So thank you very much. Will we move on to get back onto time, or does anyone have any questions? Sorry? We could have questions for later. Yep. Do you want me to introduce the next speaker? Okay. So our next speaker is a Zoom speaker. So our next speaker is Dr. Matthew Gutman. Hi, Matt.